A very good morning to all of you. I'm very much privileged to be here. Thank you, Debashish, Dr. Palash, and everyone who is conducting a very nice conference here. So without wasting time, we'll start our session with the newer approaches of pain relief in cardiothoracic anesthesia. So what we'll learn in next 10 minutes, we will understand, actually recollect the pain, source of pain and its dynamics, the importance of pain elevation, assessment of pain, and approach to different types of analgesia with a little bit of literature review. So, as we all know, what is pain? It is an unpleasant sensory and emotional experience associated with or resembling that associated with acute or potential tissue damage with some addition of key notes. So it's always a personal experience which have very much influence on the biological, psychological and social factors. And verbal description is only one of the several behaviors that express the pain. So if we do not able to communicate the pain, that doesn't mean that we don't have pains. So we have the possibility of non-communication pain, and that has to be kept in mind, especially during the OT and in the pediatric patients. So as there is evaluation of the cardiac surgery from open heart surgery to direct vision MICS, nowadays we are doing endoscopic cardiac surgery and robotic cardiac surgeries. So the sources of pain has been changed from open heart to the approaches the surgeons do to a minimally invasive, that is endoscopic and robotic cardiac surgeries. So as we see, the scars has also been reduced up to this much. So the sources of pain has been changed from midline to thoracic regions. So we have to change our pain management strategies from traditional to some advanced way. So firstly, we have to know where the pain comes from after cardiac surgeries. Firstly, in traditional surgeries, it can come sternotomy pain, and for the MICS and endoscopic surgeries, the pain is from the thoracotomy pain. Pain can also comes from the pericardiotomy, intraoperative tissue retraction and dissection, leg vein harvesting, lima and rima harvestings, vascular cannulation sites, especially in robotic cardiac surgeries, chest tube placement. The placement of chest tube is also a very much important source of pain. The intraoperative sternal retraction, the surgeons do retract the sternum, and it might cause posterior rib fractures with a brachial plexus injury with the unexplained non-incisional pain postoperatively. And there is some chronic pain that persists after the operations. It can be multifactorial due to tissue destruction, intercostal nerve trauma, stainless steel sutures, and sometimes brachial plexus neuropathy due to abnormal posturings, and neuralgia of the saphenous nerves can also happen. So we have to keep in mind that the postoperative pain that is non-incisional and persistence can be due to this kind of sources. So why do we treat pain? Firstly, it is a basic human right to reduce the pain and suffering of the patients and increase the quality of life. And we also have some clinical benefits like hemodynamic, metabolic, immunologic, hemostatics, stress response, and decreased morbidity. So how do we treat pain? So there's a 4-step model of pain management. The acute stimulation from a noxious stimuli that goes transduction, transmission, perception, and modulations. So what happens? Where the trauma happens, that is the peripheral nociceptors, from there, as we all know, the peripheral nerves go to the dorsal horn of the spinal cord and ultimately ascending track to the brain, so that we can perceive pain. And in the molecular levels, we have arachidonic acid pathways with the phosphorylation of TTX resistant sodium channels. These are all physiology we all know. So how could we manage the pain? How could we modulate the pain post-operatively? Firstly, we can modulate the transduction by some medicines like NSAIDs, antihistaminics, opioids, local anesthesia, at the site where the stimulation happens. Secondly, the transmission, that is the transmission through the nerves by local anesthesia and opioids. The modulations, we can use opioids, alpha 2 agonists, NMDA receptors, antagonists. And perception of pain can also be modulated by opioids, general anesthesia, alpha 2 agonists. As we all know, we are doing it in our day-to-day life. The pain assessment, the VAS scale, I'm not going details because we all know every detail of these scales. The numerical rating scales, this is, I think, more practical than VAS. VRA scales. And we have to keep in mind that dynamic pain is also there in cases of post-cardiac surgery patients. When we do assessment of the pain during the rest time, but during the mobilization time, when the patient comes out of the bed, take deep breathings, do spirometry, the pain increases. So we have to keep in mind that dynamic pain is also a part of our pain assessment system. So not only the intensity, we have to keep in mind that onset and pattern of pain, location of pain, quality, intensity, aggravating and relieving factors, treatment that we have given previously, effect of the treatment has been relieved or not, and there might be some barriers to the pain assessments, like cultural language barriers, cognitive barriers. Some patients have increased intensity of the pain, and some patients do not feel pain so much. So these are all important things that we have to keep in mind. In children, it's actually a difficult process. There are numerical scales that has been invented from preterm to term infants. The PIPP, I'm not going details into it. For the toddlers, there are different scales. Preschool children, school age and adolescents, there are different types of scales, pain assessment scales. That is very important, and we have to assess the pain, especially in the children, because they are not very much very much able to communicate it verbally. So these are the scales, and during operations, the patient also feel pain during operations. So there are some pain assessment scales that we use in the operation theater, that is the PPI scale, that is the pupillary pain index scale. If it is less than 3, that is good. If it is more than 7, that is actually detrimental. The patient is feeling pain, so we have to increase the dose of opioids. So this is the machine. And the last part, that is the types of analgesia. The preemptive analgesia that focuses on the post-operative pain control. But the preventive analgesia, we used to do a preventive analgesia before the pain starts. We start management of the pain. So it reduces the post-operative pain and consumption of the analgesics. So how do we manage the pain post-operatively in cardiac surgeries? We used to do a systemic pain relief, physical modulations, regional anesthesia. The systemic, that is the oral IV, that can be physician controlled or PCA controlled. Regionals can be of central and peripheral. Peripheral, that might be a surgical site infiltration or different kind of plain blocks that I am coming. Still now, the opioids are the cornerstones of the cardiac surgeries. The narcotics, as it is a very much cardiostables, we still use opioids as our basic pain relief in cardiac surgeries. Apart from that, we have different kind of opioids that we all know. We use fentanyl, remifentanil, especially nowadays remifentanil is an ultra short acting fentanyl. That is very important for recent advances in cardiac analgesia in cardiac surgery. Still there is a option for non-opioid analgesia. That the non-opioid analgesia also have integrated into the pain management of cardiac surgeries, and it has been found in different studies that the low and ultra low opioid use was not associated with significant differences in postoperative outcomes if we use non-opioid interventions along with the opioids. So NSAIDs, the role in cardiac surgery is very limited, but still it has a synergistic effect and opioid sparing effect in cardiac surgeries. Now the ERAS in cardiac surgeries, there is multimodal analgesia is everywhere from the preoperative, intra, and the postoperative periods. So just 2 minutes, we can use PCM or gabapentin, ketamine, dexmedetomidine, and SAP blocks previously to reduce the pain in cardiac surgeries. So there are different regional techniques of cardiac surgery, like that is the paravertebral block, thoracic epidural blocks, caudal epidural blocks, especially in children, USG guided always, chest wall blocks in endoscopic cardiac surgeries or minimally invasive cardiac surgeries. We have PEC 1, PEC 2, SAP blocks, superficial and deep, and erector spiny blocks. These are all blocks that we can use in ultrasound USG guided always in cardiac surgery, especially in the minimally invasive and robotic cardiac surgeries. So there are a lot of literatures are there, and they have proven that the effect of blocks is very much opioid sparing effects. So, and there is an option of paras channel, that is the paras channel block, that is continuous IV infiltration of local anesthesia besides the sternal wound. That is also very important. And some recent advances that we come with a Didopor, that is a ER formulation of morphine with a liposomal carrier. And there are encapsulation of the bupivacaine that can be used as a parasternal block during the sternotomy. And there is a more potent releasing version of paracetamol that is coming up in our recent days. PRCA, that is an intranasal opioids as a dry powder or a nasal spray. Capsaicin, it's a non-narcotic potent analgesics. Tapentadol, these are all the newer analgesics. And we have to keep in mind that the acute pain service system that has to be there with a dedicated team. So optimal pain management is a right for all the patients, and it is a responsibility of all health professionals. Thank you very much for patient hearing.
So thank you.